Welcome to a Shot in the Arm podcast. I'm Ben Plumley, and this is the podcast about innovation and equity in global health. Now, in this episode, part of our informal take on global health security, we're taking stock of how resilient the world is in balancing what now seems to be endemic COVID, while sustaining existing infectious disease responses and preparing for Disease X, for future pandemic threats. All of this in the midst of great geopolitical and economic turmoil. To help us make sense of all of this, I'm joined by two giants of global health diplomacy. Ambassador Mark Dybul, co-director of the Center for Global Health Practice and Impact and professor in the Department of Medicine at Georgetown University, and Ambassador Eric Goosby, friend of a Shot in the Arm podcast, professor of medicine and director of global health delivery and diplomacy at the Institute for Global Health Sciences at the University of California, San Francisco. Now, they're both former global AIDS ambassadors and coordinators of PEPFAR, Mark under President George W. Bush and Eric under President Barack Obama. Mark went on, of course, to be the executive director of the Global Fund to fight AIDS, TB, and malaria. And Eric, of course, the UN Secretary General's special envoy on TB. Gentlemen, welcome to a Shot in the Arm podcast.
Thank you.
Good to be with you, Ben and Eric.
So we're having this podcast, literally recording it at the same time that we have the COP28 taking place in Egypt. And I just wonder, actually it's COP27, isn't it? And I just wondered what you both think of how health is being presented at this conference and in these conversations about climate chaos and just how all of this relates to old, current, and new pandemic threats. Mark, I don't know if you have thoughts on this first.
To be honest, I think we're still a little bit too focused on the pandemic threat, which we absolutely need to be, new pandemic threats, but we're not connecting the dots. If you think about the Venn diagram of what are the root causes of climate change and what are the root causes of poor health, it's a pretty massive interlay. We tend to focus on climate change increasing the risk of new bugs or old bugs like malaria coming into regions they haven't been because it's getting warmer on tops of mountains, and or the recent bacteria being released from glaciers and things like that. Whereas if we think about what are root causes of climate change and health, urbanization, pollution, proximity of people to animals as we're getting closer and closer to animals, the pesticides, herbicides. The UN recently reported that we've passed the safety levels, health safety levels for every type subclass of pesticide, organophosphide, and that those are real health risks to humans. But we don't connect these dots, and so I think the conversations are there, but they're not there in a concentrated, focused way. And I think we could take some time to just do a Venn diagram of what are the root causes of current issues for health, but also future threats to health, and then start addressing them in a systematic way. Eliminating mass production of animals, for example, and getting back to regenerative farming, which would be phenomenal for the environment, would also have tremendous health benefits immediately by the damage done by pesticides, herbicides, organophosphades to humans, but also be the best thing to prevent the zoonotic jump of an animal, from an animal to a human. So the conversations are there, but they need to get a lot more sophisticated and faster.
And you're basically referring to, I think in part, well, I guess out here, we sort of invented it, didn't we, Eric? Certainly UC Davis was at the forefront of defining One Health. And I've got my head around it over the last couple of years, this interplay between globalization, closer interaction with animals, and then the transfer, as you said, the zoonotic transfer of new pathogens. But Eric, I wondered. You have been, well, both of you have been masters at joining the dots. But how do we from the global health community, do you think, incorporate climate chaos into our thinking? We still seem to be a little bit siloed, I think.
No, I strongly agree that with Mark and you, Ben, that this is truly a threat that we have allowed to be in the background in the medical community and in the response in the medical platforms to the threats presented by global climate change. There is a huge overlap. We also don't define the response specifically in disease progression, kind of maldistribution of incidence of disease as a function of climate changes. Mark outlined most of them. And I think we do a disservice to other scientists in the field that are non-medical and to the population community at large, because it's a complicated dot connection exercise, but a real one that has been there and it's been measured in part. The observations and measurements have increased over the last 20 years, but the reaction to that data has either not been, which is most common, or has been less than optimal or less than even the minimal response needed to change a trajectory. I think the cry in the meetings in Egypt we're at the point where it may be too late, and they still don't kind of articulate the specifics of that. So I'm frustrated with it, but I have to own the fact that the medical side of the equation has not aggressively engaged this. I think the One Health, the idea of antimicrobial resistance that comes out of that is the only thing that Mark didn't bring up in his list, which we all see as imminent. And in tuberculosis, it's especially scary, with the leading resistance patterns being in the response to treatment of MDR and XDR TB. There needs to be a rekindling and a crescendo of import by medical community, climate community. There's scientists and medical people who generally don't talk to each other. That is slowly moving together. The UC Davis team has been championing just what are the relevant pieces of their work that the medical community needs to respond to and incorporate in both research and in diagnostic treatment responses. I would only end with the inequities in maldistribution of exposure and outcomes as a result from renal disease to direct toxins from organophosphates that Mark mentioned are pathetic. We've known about it and understood it and have not reacted to protect. And there's no excuse for that.
Well, while we're on a downer, the other thing, of course, context-wise, is the outbreak in Uganda of a new strain of Ebola, the so-called Sudan strain. And I just wondered, both of you, how seriously should we be taking this? I see that, numbers are increasing, including infections and deaths in healthcare workers. And of course, our existing Ebola vaccines are not proven to be effective against them. How worried are you about this outbreak?
Well, I could say worried. The numbers have been kind of under the 150 mark, kind of creeping up. The deaths have gone up with that. Healthcare workers are always the first hit, disproportionately hit in Ebola outbreaks. The way the awareness in the community generally is generated comes usually from a healthcare site and the personnel in it who first engage it as kind of a formal engagement and not just a family reacting to a sick relative. And I do think that it has not crescendoed as much as I have to admit, I've kind of lost track with exactly where it is in the last couple of weeks. But at the end of October, it looked like it was plateauing out. But I know these things, have daily inputs that could change that. So I have to plead a little ignorance to the specifics of where the outbreak is.
Mark, what is your sense?
Well, whenever there's a new strain of any virus, we have to be worried. But I think we can be pretty comfortable where we are with it. I mean, first of all, Uganda has a long history and are doing it again of responding quite well to Ebola outbreaks, and they're doing it again. And the surrounding countries are now teamed up, and WHO is doing a fantastic job. I think it's a good example of how regional activity can function, which doesn't surprise me because Africa as a continent had the best regional response to COVID of any region in the world by far. And John Kengasong, who is now running PEPFAR, had a huge role in that. But the heads of state got on it right away, and WHO is deeply involved. And so I think the response has been as strong as it can be. 50% of the cases are still in a single county. There are no cases reported outside of Uganda yet. And they know what they're doing. Their case contact rate is exactly where you'd want it to be, relative to the number of cases. They're approaching, I think, 10,000 case contacts with 15 cases or so. So, they're doing a fantastic job. And but you're always worried when a virus is a new variant. But it just doesn't seem to be fundamentally different than Ebola, which is never going to be a global pandemic.
Because it burns itself out too quickly, right?
Other things are going to be, yeah.
Well, and that nicely gets us on to I think the core and perhaps the positive start of the conversation around just how resilient our health systems have been, through the period of COVID, through a period where we've been trying to maintain our response to AIDS, TB, and malaria. But Eric, WHO recently released, actually, I think, a very nice graphic report on the impact on the TB response, noting, unfortunately, that number of diagnoses had increased and morbidity, mortality had increased. And yet we also saw, courtesy of Global Fund investments in different parts of the world, and I'm thinking particularly of Bangladesh, that the infrastructure that had been developed to handle TB was mobilized and pivoted to help manage COVID, and then was able to pick up. And countries like Bangladesh are actually ahead of the curve in terms of diagnoses and monitoring. So just what's your sense of how resilient our health infrastructures have been globally?
Well, I think that that phenomena was seen everywhere. The people who were asked to respond to the COVID outbreak were also the people involved in HIV and TB care specifically, both at the clinic sites as well as in the community. Those networks and platforms were already laid and appropriately were used to move both educational information and, when available, vaccine testing, and in a very small number of cases outside of developed settings, treatments. I think that the overwhelming emphasis on it, the pendulum swing toward COVID and back to HIV, TB, malaria type programming, it has started. The awareness of the displaced attention to the diseases was evident immediately and monitored. So I think people knew it was going to happen, knew they had to let it happen, but also saw that it was going to be important to keep a quantitative awareness of the displacement of effort for the ability to return to that pre-COVID moment. and better understand the expanded need that COVID represents post the actual kind of thrust of their outbreak. It presented to us a glimpse of how platforms, when in place, can be rapidly mobilized in areas that are the same type of work and skills needed, but also become the platforms where retraining and combining new partnerships really emerged. And I think that is also part of the story.
So Mark, let me come to you on this, because you were a member of this independent panel for pandemics response and preparedness, looking at how well we did. And you also had some pretty tough recommendations for going forward, which we'll get into. But at a 38,000 foot level, what did the panel think went well and also went wrong?
Oh, the well part's a little bit easier, not much. I think it was a catastrophic example of the failure of our international systems, I would say, to respond. I think WHO did a fantastic job, as good a job as they could under the circumstances and the gross limitations that are placed on them, and the unrealistic expectations. But I think at root, what it revealed is we do not have an international system to respond to pandemics, international to regional to national, and actually the other way around, from communities to nations to regions to an international network to identify threats, respond rapidly to them, and prevent them from. We're going to have outbreaks. We are going to have outbreaks, but we don't have a system to identify those outbreaks and respond to them. There's also been way too much emphasis on surveillance. I mean, it's not like we knew in mid-December, and certainly by mid-January, that this was a real threat. No one did anything until April, May, June, and then that was a nationalistic, terrible response.
Well, I wanted to pick up on that, because for me, the most heartbreaking aspect of this, and having spent a career in trying to build effective, sustainable models of access to treatment, we displayed in the global north appalling sort of vaccine populism. Well, it wasn't just restricted to
let's be honest, we did the same with antiretrovirals. It wasn't until we had our HIV epidemics under control that we even began to think remotely about the massive number of people in Africa and what we could do there. So this isn't the first time we've done that.
Why didn't we learn from it, though?
Well, we have a tendency not to learn from anything. And yet, to be honest, we're no better off 2.5 years in than we were at the beginning. I think we've actually taken a step back. One of the things that went well was coordination and interaction among the R&D community, and sharing of information in real time, which allowed us to develop vaccines in a very rapid period of time. We got very lucky there. People are, I think, way overestimating the capacity to respond to more complex viruses. But look at monkeypox. I mean, for God's sake, we have a vaccine stockpiled. We have therapies stockpiled. We have diagnostics available for a virus that doesn't spread quite so easily, and it has been pretty contained. And we still messed it up 2.5 years into COVID. I mean, how much more of an example do you need of our absolute failure? And from a nationalistic perspective, I mean, it's been reported, and just appalls me, that the US allowed 20 million vaccine doses to expire in our stockpile rather than sending them to West Africa, where the disease is endemic. I mean, how much more do we need to learn that those 20 million doses could have prevented monkeypox from breaking out theoretically into a global pandemic, and we let them expire on our shelves.
And we did that because we didn't consider sub-Saharan Africa to be a priority globally. This concept of nobody's safe until everyone's safe is not something that is really embedded. I think that's what I'm hearing from both of you in our political discourse. There was one other element of the COVID response that I thought was really pretty terrible, and it comes from actually health infrastructure that you both were instrumental in establishing. South Africa's diagnostics and surveillance management systems. And in South Africa, they identified the Omicron variant very early on. And what was the world's response? We closed our doors to South Africa rather than seeing them perhaps as the canary in the coal mine. And again, why do you think we got it so wrong?
We did get it wrong, and we've never really gotten it right. The reality is we have an idea of a global health community that acts rationally and responds to data. But the truth of it is that there are pieces that are functional and pieces that are non-existent, and the overall gestalt becomes a dysfunctional, episodic, non-accountable system. And I would underline the lack of accountability. We have already sensitized populations to healthcare, to who gets healthcare and who doesn't get healthcare. The idea that you can buy healthcare and if you can't pay for it, you don't get it is deeply accepted and internalized in most of your developed world settings. There are exceptions, but most of your developed world accepts that dynamic. That construct limits, preserves inaction, and allows for, in the face of data and information, a lack of a coordinating nucleus. And I think that we've not reached the threshold where the ideal description of an international health response and IHR in the 2005, a good description of how it should work, doesn't. And I guess I have to say that the rise of awareness of this inability to allow people to benefit from the science we already know has not come with us in climate change, and it certainly hasn't come with us in global health threats. And even when they threaten security issues, we still recede to a nationalistic response. And it's largely because those are the systems that we can engage with. The systems that kind of go between national agendas are not strong or non-existent. So it sounds awfully negative, but I think that is an honest description of where we are.
Well, there's something No, go ahead, Mark.
Go ahead. I completely agree with Eric. I think the root of it is we continue to think of pandemics as primarily health issues and look to the World Health Organization, which is a member organization of ministers of health, who are often the least powerful people in their governments, or among the least powerful people in their governments. Pandemics are primarily socio-political economic phenomenon generated by a health threat. But they're not, the response will never succeed in the health sector because it is fundamentally socioeconomic and political. And that's why you have closing of borders when it makes no sense, when all of us in health knew that it probably didn't even start in South Africa. I know it didn't start in South Africa, but they identified it. And so what we respond by politically, by shutting down our borders. Well, the proper response would have been sending as much money in as possible to identify it, which is what they did, to basically give them an incentive to report it. Go back to the original Ebola, not the original, but the catastrophic Ebola outbreak about a decade ago, when it spread across countries, and this happens over and over again with diseases, countries don't want to report them. So they get out of control before they're reported, because what's the response to them? Well, this happened with Mexico with H1N1, where people use the outbreak of H1N1, even though it had nothing to do with the pigs themselves. It's called pig flu. To other parts of Latin America that didn't want to import pork from Mexico for nationalistic reasons, started cutting off pork from Mexico because Mexico reported H1N1. So we disincentivize the interaction that is necessary by these kinds of responses, whereas the right response, and here the IPPR and the G20 panel have basically the same recommendation. David Miliband, give him a lot of credit for putting it forward. We need to have a pool of money in the hundreds of millions that you can actually have forward funded, basically, that you draw down on as soon as there's an outbreak, and hundreds of millions of dollars go into countries that raise their hand, so that you can stop the going from an outbreak to a pandemic. But instead of that, what we do is penalize them. And so why would someone raise their hand? So, the whole system, until we link the health to the socio-political economic, which we do not do, you're not going to get out of this. And that's why the principal recommendation of the panel, that everything flows from, is that you can't do one thing. So everyone's now, let's do surveillance, or let's do human research, let's do better pharmaceutical. You can do each of those pieces. We're still going to have pandemics until you have an organized structure that emanates from the countries and country ownership in communities to the country, to the region. And really, that's where the focus of work should be. And then international at the head of state level, because only heads of state can manage the socioeconomic, political consequences. And then you have to have all the sectors involved, which is something we learned from HIV. Without the private sector and the faith community and those deep engagements at the very beginning and in the response, it never would have worked. But the private sector is just supposed to do pharmaceuticals, when the private sector is where a lot of people work and they can be involved in prevention and response. We do not think in an interconnected way, which goes back to our first conversation on COP27. We are still just I would just say that our global institutions have done phenomenal things and had phenomenal responses, but none of the organizations that exist today, national or international, are built for rapid response or for multi-sectoral response. And until we remake and restructure ourselves, we will always be slow. We will always be behind. And we cannot, with our current organizational structures and the way we think, we cannot respond. So what
you're saying is that the kind of multi-sectoral response that, again, the three of us were involved in, and me particularly from the community and then the private sector, broader private sector response that we thought we were getting together in the early 2000s. Many of our listeners and viewers coming to this new will not be aware of that. And we haven't been able to institutionalize and develop that further. But here's the thought. Coming this fall, we had the 7th replenishment of the Global Fund to fight AIDS, TB, and malaria. And, it is a platform, if you like, of country-led programs, as you were describing, Mark, that has had a huge impact over the last 20-odd years in saving lives from AIDS, TB, and malaria. And it started to adapt and have become part of the COVID response. We saw that in many settings, and the way that its funds were able to be diverted or reprioritized, I should say. But at the end of the replenishment, we didn't achieve the $18 billion that we were looking for. We did achieve just over $14 billion from a range of governments and foundations and others. And I guess two questions for you both. Do you see that replenishment as a success, as a failure? Was it glass half empty or half full? And then whether we can really start looking at the Global Fund as a platform that we could adapt in other settings. But the replenishment itself, what were your thoughts on that?
I'll let Mark go. He spent so much time in that orchestration.
Having run two of them. I think it was an unqualified success given the circumstances. So you had the United States and President Biden hosting, which is phenomenal. It's the second time. President Obama also hosted one. I was privileged to be executive director at the time. because the United States, Germany, Japan, the European Commission, a number of Nordic countries, increasing their commitments by 30%, despite everything else going on in the world. The fundamental problems were Italy and the UK, and those remain the fundamental problems. Neither one of them pledged, and that's why the number is so low. And we still don't know what their pledges are going to be. And certainly, the new government in Italy is not. I would not be putting some bets down on much money coming out of Italy, which is a shame. The UK, they could cut. They're cutting everything. They're cutting all of their international commitments, and some by 100%.
Yeah.
So we have to wait to see what the new government, or maybe next week we'll have a new government again in the UK. But, whoever the new government is actually going to make the decision, fortunately, the UK's relationship with the US is probably its most important relationship, and so since President Biden hosted, hopefully that they won't go to zero; they'll go to somewhere in between.
Well, the other thing that is in
be able to do it, and also the links to global health security. So that was the United States. I mean, the United States put $3.5 billion in the global fund, and no one else followed, and that's a problem specifically for pandemic response. Then the U.S. Congress led on that, but the administration was fully supportive. And I think that was a hugely important move. And Rebecca Katz, before COVID, actually, had done an analysis of the Global Fund. Rebecca Katz at Georgetown too, but and was in the administration, one of the leaders in the world on global health security. She did an analysis of the Global Fund pre-COVID and said, look, a third of the resources you can easily count as going towards pandemic preparedness and response, because of the investments in systems, what you would use for case identification and finding, the laboratory infrastructure, the links between communities and the region, the within the countries regionally and then nationally. All of this is part of pandemic preparedness and response. So there's been no greater investment in health systems than has gone into HIV, TB, and malaria, which includes the United States response through PEPFAR and the President's Malaria Initiative, through the Global Fund. And those massive investments of the last 20 years in systems that allowed for, and this is so important in the case of something like HIV, lifelong therapy, which is very different than shorter-term therapy for malaria or even TB. You have to do lifelong therapy, and the system you need for lifelong therapy is fundamentally different in every aspect: the healthcare aspects, the supply chain aspects, and logistics systems, communication systems, all of that.
And monitoring systems,
are the basis for the response to any pandemic. And if you want to maintain them, and this is something we did at IPPR, why did some countries do well? Well, they maintained, after SARS, their pandemic response systems. The only way to maintain those systems, because we're going to have pandemics intermittently, new pandemic threats intermittently, is to fight current pandemics. And that's how you maintain the systems. And HIV, TB, and malaria in some parts of the world are the fundamental systems. In other places, you could do it around hypertension, diabetes, whatever the threats are, health threats are, and integrate these. But you're not going to maintain a system for something that happens once every 5 to 10 years and expect it to function. Use the current pandemic systems, invest in those so that they have the surge capacity to respond when needed.
Well, that's our top line message out of this podcast, and there is an aspect to this around the therapeutic and prevention diagnostics approaches that I want to come back to you both on. But Eric, going back to Mark's comments about the United Kingdom, our friend Andrew Mitchell has been appointed the overseas development secretary, and he's got a place back in cabinet. What do you think we need to do to get the British to step up to the plate? Because it's sort of, they're beginning to see this. There wasn't going to be senior leadership at COP, King Charles, but Rishi Sunak showed up in the end. Do you think with someone like Andrew, we have a chance of getting them to see sense?
Yes, I think Andrew's role in his shadow government position in 2009-10 really spoke even then to a lot of the issues Mark brought up. I think that he, for reasons of his background, has a deeper understanding of the infrastructure needed around pandemic preparation. I think Mark's statement of the way to prepare for a pandemic is to keep responding to it um, is really a very clever way to give people a understanding of the need for that commitment to a function that can wax and wane, as you put it, surge with need, but never really fades away. We're smart enough to do that. We can prepare people, especially in the shadow of an event close. But I think that when you're close to the actual outbreak. But I think that the dialogue that's needed in the UK will be needs to be aggressive, and I think he will be able to actually put a purse string around it and deliver it. So I'm thrilled that he actually has achieved a cabinet position. I know we've all talked to him over the years, but I haven't spoken to him in a couple of 3 years. But now this makes it exciting that he's being valued for the knowledge and, I think, role that he uniquely offers. Great
Now,
news.
one of the other things that you've both touched on is this multi-sectoral approach, and a companion piece to this episode will be one that we're doing with frontline aides, looking at the pandemic response for whom, with local communities. But in this section of the podcast, I'd really like to focus on what we see the role of the private sector, particularly those working in the healthcare field. And so to kick it off, I feel, and as someone who's worked very much in this field over the last 20 odd years, I feel that we've taken some steps back. The inability to make vaccines truly global, and some pretty ridiculous, I think, half-assed efforts to try and then make a few vaccines available on occasion should the wind be pointing in the right direction. Industry itself has taken a step back. But I think there's also been some steps back in UN leadership, taking a more confrontational approach with the vaccines, pharmaceuticals, and diagnostics industries. And I just wondered where you both see us going from here. We've all tried to build these kind of public-private partnerships, but they don't seem to have had the resilience that we would have hoped for in the COVID experience.
I can speak just briefly to the need continuing and the frustration in being unable to kind of find a formula that is acceptable to the corporate ROI drive and the needs of the larger population, who really will never be able to respond with the pricing that they come up with. And I think creating a space where the discussion around the need to please shareholders and embrace a profit, matched with the need for increased access and availability to the populations that need it on a medical scientific level, needs to be part of our approval process for drugs. Not to create an enemy, but to truly create the partnership that we haven't achieved in working with the R&D aspects of drug development that are also linked to drug access, and especially in low-income countries. I believe that we are smart enough to put that discussion together in a protected way that allows for the corporate needs to be flushed out and clear in the discussion to kind of the global community, who ultimately needs to find the resources to cover this. So, yeah.
So bear me out a second. I think honestly, it's probably fairly obvious for treatments and for vaccines. And I noted that you all and our good friend Peter Piot called for, local manufacture of vaccines in the South as part of this overall preparation. But, and you both know this, I've become quite obsessed with what's going on in the diagnostic side of things, particularly as long-acting injectables come into the play for the management of HIV prevention and treatment. And what has really surprised me is that there is a really fundamental lack of understanding of what the technology is that we have, how it might be used, but also how we produce it. And this, I'll give you an example. There's a recent report from Path and Accenture looking at access strategies for diagnostics. It's good, very good in parts, but it makes the argument that the model that we took for HIV therapies could be applied to diagnostics. And I think they were imagining that these were all point of care, or what kind of point of care diagnostic tests, I'm not really sure, but that you could manufacture these locally and, wham bam, you've got the diagnostic side of it. Whereas in reality, it's much more complicated. There is this interplay between the need for strong, high-throughput, lab-based diagnostic networks with frontline point-of-care tests. And again, the question of availability and affordability of those frontline point-of-care tests is also up in the air. So how might we start going about getting the international community to think more effectively about how to deal with that side of the equation? How do we root our conversations in evidence and science and not aspiration?
So, a lot of groups have called for local manufacture, but it has to be intelligent manufacture. We've been having these conversations around HIV drugs for a long time. And IPPR, and others, and the Africans themselves have a long-term sustainability plan. I think the conversation is misplaced talking about manufacture, to be honest. You have to own discovery. We will never get out of manufacture. If your target product profile begins with, we can have a -70 requirement because we can do that in high-income countries, you're never going to have access for a long time.
When you say -70, you mean in terms of the temperature for storage?
The RNA vaccines required, the early ones required -70 degrees. But if your target product profile is agnostic to your temperature requirement, it's by definition not going to be global for a long time. And that's exactly what we see, right? So you have to own discovery. And I also think this is how we get out of a lot of our world's problems. We talk a good game on innovation, but we don't fundamentally have innovation. We have restricted access to innovation in the same way we have restricted access to production. And that restriction on access to resources for discovery, for research and development, beginning at discovery, going through translational until you own that, you will never get out of it by having production capacity alone. Nor will you be able to ever export that. If you can produce at a lower cost, you will never be allowed to export it because you will be restricted from doing so by the licensing agreements that allow you to manufacture. So I think what we need to be investing in is opening up innovation in low and middle income countries where phenomenal ideas are and great people and institutions. And if we let a new generation, and Africa is 75% people under 25, you don't need the educational doctoral system. You don't need all that stuff. I swear to God, a college kid could come up with an RNA vaccine with what's published right now. We build all these structures and things that limit access to discovery, that limit access to research and the research and development processes. We don't need to be doing that. And so let's invest in all of our future, because innovation is all of our future, and invest in actual innovation and kind of take the shackles off of the early parts of research and development, which was discovery and innovation, and the translation and how we do clinical research and where we do clinical research and how it's funded, and switch to a global innovation opportunity. That's how we get out of this mess. We can do all we want on production. It's not going to solve the fundamental problem nor will we ever have the rapid responses that we're going to need unless we have everyone in the world, all this innovation possible. That's how we can solve climate change. We can eliminate pesticides and we can solve nearly all of our problems if we actually unleash innovation from the beginning with discovery, and then allow the production piece to happen. But not just allow, but invest in it. But we have to do the end-to-end parts of research and development in an open, innovative way, and that's how we get out of. That's the only way out of this problem, in my view.
So that I think makes great sense to me from the therapeutics and from the vaccine side.
And diagnostic.
But we all want, I guess, to get to a point where we have a low cost, high performance, easy to use diagnostic, multi-platform, i.e., that it covers a lot of pathogens, HIV, TB potentially, but also perhaps some non-communicable disease functions as well. But the technology isn't there yet, and so I think it's important that we focus on that aspirational. But I remember in the early days of the 90-90-90 campaign for 90% an HIV campaign that UNAIDS launched around, 90% of people know their status, 90% have access to antiretrovirals, and 90% have undetectable viral loads. And the call was, we need viral load and we need it now. We need point of care viral load and we need it now. And it didn't exist. It didn't exist in the form that we wanted. So what would be really interesting is to get your sense of how we make these trade-offs now, and how we ensure that we are able to monitor, first of all, diagnose effectively. And I think, for HIV, the Global Fund and PEPFAR has gone a long way there. But how do we do that in a way that is sustainable and really does bring the kind of country engagement? And, could there be economies of scale, I don't know, between urban and peri-urban areas? I don't know, Eric, what are your thoughts on this?
Yeah, really stimulating thoughts from both of you about this. It's a huge issue. I think that what makes the most sense to me is the marriage between focusing on what would be the marriage between private sector and public sector agendas, and where would be the forum, the platform, the site where that discussion and those partnerships could be fleshed out and achieved. Because I think finding a way, an innovative way, to allow for profit to be generated by bundling up tests. This is something that I've talked to both of you about individually, but allow for a bundling of tests on platforms we've already built in disease sectors like HIV, like TB, like malaria, maternal and child health, reproductive health. There are platforms that are people and sites and procurement distribution systems that are present, that with a mind that thinks in terms of how can we put diagnostics together that address the disease prevalence of these diseases, both infectious and NCDs, in this population, using these same platforms, we might be able to see a profit-generated effort that allows for the presence of these diagnostics in settings that would never be able to afford them. And I believe we are smart enough to do that if we allow, like Mark is saying, that innovative energy to perfuse the discussion, and especially in settings where that approach is not supported, taken advantage of.
Now, you've both been very strong supporters of the African Society for Laboratory Medicine, ASLM. as a way of harnessing and empowering that creativity from the region itself, which I completely agree is really where the action is going to be at. I wonder that I think there is a role for them. I hope Nkobile won't mind me saying this, but for them really to lead the charge here in determining, what it is that they need, and helping us understand how we support that, what we need to do. And does that resonate with the pair of you? Do you see this kind of sort of institutional Southern leadership helping us drive the agenda?
It has to. It's the only way to do it. I mean, again, just go back to target product profile. What interest would it be for a large pharmaceutical company to come up with a rapid test that will include tuberculosis and schistosomiasis? And I mean, there is no incentive or to do a rapid HIV test. We don't need them in the US and Europe. We don't need them so what incentive? There is no incentive for that TPP. The only incentive is if it's driven by people in other parts of the world that have different health needs. NCDs are, of course, for hypertension, diabetes, but in the US and Europe, we don't need it to be 50 cents. In fact, companies don't want it to be 50 cents. So, you have to have the target product profile developed by the people who are going to be affected, which means having communities involved from the very beginning in research and discovery, which is what we're trying to do on HIV cure in Africa and a whole bunch of other things. But the community needs to be involved from the beginning. Had an African group been involved in the early TPP for the mRNA vaccine, no one would have said, let's start with -70, right? So it has to be driven by people on the ground who know what they need. And then they have to be resourced to have the innovation to come up with the products and to produce the discovery through to production.
So sort of stepping now to the broader global health security agenda, and I realize we're coming up to the top of the hour. There was something that Helen Clark said, Helen, I think, was one of the co-chairs of the independent panel, Mark. And she said that it was so noticeable that the IAEA, the UN Atomic Agency, was able to get into Ukraine and into the nuclear reactors. But the same kind of access was not available to the public health community to get into the key labs that we needed to do so. And it just struck me very forcefully that here was an example of where we just aren't at the same table. We're just, or we might be at the table, but we're not at the top of the table when it comes to responding to clear, present, even imminent threats. And just what is your sense of how we drive health into the global security agenda? Do you want to start, Mark? I can't believe I shut you both up. That is a first.
I was waiting for Eric to answer first because I just did the last answer. But this is an area I think a lot about because, the next pandemic is as likely to come from, I don't believe this one came from a laboratory. I'm pretty certain the data are clear on that, but we'll never know for sure. But similar to atomic energy, our biggest threat for biosecurity is intentional or unintentionally. And there are people intentionally trying to create weaponized pandemics, for sure. We know this. But it can also happen accidentally, depending on how we're doing the laboratory work, if it's not properly controlled. That will require a global treaty and agreement to do so, which is what Helen's talking about, and IPPR does call for a treaty. But let's be clear, IAEA hardly gets to all the problems, and what often happens in these things are the good actors follow the treaty and the bad actors don't, and put up roadblocks to it. So I agree completely with Helen that we need such a structure, but then we need to be clear-headed about what it can and cannot do. And it's not just looking at those bio threats, but part of it is to evaluate countries' ability to respond to a pandemic threat and then support them. But if it's punitive rather than supportive, it's never going to work. And IEA still is more punitive. So how do we change the incentives to supportive rather than punitive in all regards so that we can get better answers? But then we should also be looking at the pure biosecurity of weaponization of pandemic threats, which is increasingly possible.
I would just agree with that and say that the support for a review and investigation, when supported by the largest economies in the world, will get access to it eventually. And I think that the IAEA's clout, being a treaty, which does put it in a different category, has the backing of kind of the world in a different way. Post-COVID, people now, I believe, may see the ramifications more clearly connected to the pandemic carnage it creates, and may be willing now to think about a treaty for a health-related issue, which I know was the recommendation. But so leave it at that.
And there's an active, Don Yamamoto was just appointed by the administration to be our chief negotiator, and the negotiations have been going on. But treaties don't solve problems either. They help, but they don't solve the problem. It just gives you a framework. You have to actually invest in and maintain those systems, which comes back to the principal theme. Let's respond to current pandemics and build the system so they can search to respond for other pandemics in all ways, including new technology, new approaches, while we're protecting ourselves from biosecurity risks.
So we're sort of come to the end of our time. Is there anything that we've missed? Anything that you think in the context of this conversation that we ought to flag up? Say, for example, John Nkesengong's leadership of PEPFAR. What do you want to see from him? We didn't really cover PEPFAR in great detail, although it's both firmly in both of your DNAs. But other things that we haven't really touched upon?
I guess I think you've done a broad brush. I think it has sounded maybe a little too negative, even though it should sound negative. I do see hope, and part of it is John Nkengasong's taking over of the PEPFAR platforms and his deep understanding of the struggles that sub-Saharan African countries in particular, but also globally, are in, both with the COVID response, but also the response to the three diseases. He has an unusual background that gives him credibility in both political and scientific arenas, just as we need that convergence to be intensified. If Africa can lead that march, at best, at a minimum, be central in that march, I believe that John will be able to find that space. And I know Mark and you both are committed to supporting that effort, but I believe it's the effort for the planet. The movement of platforms into a broader response to the needs of the same populations we've already captured with three diseases. Using those platforms to now stop those same individuals from dying from hypertension, diabetes, and coronary artery disease undiagnosed and untreated. It's time to move without a receding of the effort, but a completion of the promise that we've already started. That's what it is for me.
Yeah, I'll just agree completely. I mean, John was an inspired choice. He is going to be the best coordinator ever. Sorry, Eric. I think he's got. It was just a remarkable choice, and I think what the State Department and the administration has proposed in terms of consolidating all other pandemic work in the State Department, which is kind of scattered, into one office, and to dual hat John both as the PEPFAR coordinator and to oversee that. is exactly what's needed. And I think it's what, the Africans, let's be honest, they had to give him up as the head of the Africa CDC, and he's spectacular. Africans expect him to be involved in pandemics. There's a reason they were willing to, let him go. And not just the pandemics of HIV, TB, and HIV and TB and other pandemics that he's directly responsible for, TB related to HIV, but also broader. And so I think the State Department's taking the actions, and John's exactly the right person to be able to figure that out. How do we strengthen the HIV response by having the systems in place that will allow us to get to the end of the AIDS epidemic, but also will be there for surge for other pandemics. And as Eric said, his political clout, I mean, he has heads of state on his speed dial. I mean, he was their go-to guy, and he's so respected in all of the world. He just received a big award in Berlin, totally appropriately. So he's got everything it takes, and I hope everyone gets behind him and supports his vision as we approach the 20th anniversary of PEPFAR in coming May. There's been many of evolutions. PEPFAR does not look, Eric evolved it, and it's evolved and evolved and evolved as it should. Now is a key inflection point for another evolution, and John's the right person at the right time. That feeds into the entire conversation we had today.
Well, with that, what a nice way of bringing this conversation to a close. A message of hope and enthusiasm about our next generation of leaders. Mark, Eric, thank you so much. You are shots in the arm. Well, that's it for this episode. Thank you to Eric and Mark. Thanks also to our director and producer, Eric Aspera from NewsDoc Media. A Shot in the Arm podcast is a project of the Global Health Reporting Center and a member of the Health Podcast Network. This episode was produced with kind support from Roche Diagnostics. And finally, a big thanks to you. Have a great week and a safe week, everyone.